Now, for those who are talking about you, what our deputy president was saying in Colombia, if you've not seen a tiger in this country, you're not in this country.
Even on TV.
Kenya has tigers. That's it.
We do.
Yeah, can you stop arguing?
I'm not arguing. I'm merely asking if we do.
No, I'm saying, can people stop arguing?
Or I should stop asking questions.
Was he saying tiger? I'm a tiger ile ya cheetah.
Amelia
See,
leopard.
that's the thing now. Now you start to get it.
Okay.
I understand. I'm with it.
Ama ile ya haina.
Inaweza kuwa ile
You
ya haina ama ile ya cheetah ama
Yes.
ile ya lion.
Hata
But ni tiger.
hata elephant.
Yeah. Tiger, leopard, lion.
Yote ni
Tiger.
Ni tiger. Surely.
You know, the next thing he's going to say, at a pussycat. In the
But that's what I've said.
Okay, niendeleni.
We talked about this earlier as we were talking about the conversation we're going to have. Our Health Friday conversation today is looking at childbirth, pregnancy, managing of pregnancy into safe delivery of babies. Now, the statistic that is quite shocking is that 1 in every 4 births in the world is babies who are born too early, born too small for their gestational age and such. And it's a big one. So those ones contribute to very many other complications for these babies into the future. Either they may not survive, and those that survive still grow up with complications. Now, apparently a study was conducted by several health experts from across the world, including Kenyan experts, on this particular one, and what leads to this and what needs to be addressed here. One of those global participants of a global Lancet research is Dr. Hellen Nabwera. She's here. We're in the company of greats. Dr. Hellen Nabwera is an associate professor and physician scientist at the Aga Khan University. Welcome, Dr. Ari.
Thank you very much. It's a pleasure to be here.
This is Kenya's biggest conversation. Where else would you be having a conversation about a global research than here?
Absolutely.
Sindio? Ni hapa.
Yeah.
Okay. You'll tell us about that, about this research that you're conducting and what you found, and especially how it impacts Kenya and children in Kenya. But let's welcome you to the conversation. First, Bwana Muga
Yes, please.
has the day's proverb.
Yes.
And this week's proverbs have been from Sierra Leone.
Yes.
And today's proverb is
from Sierra Leone.
Oh.
Okay. Sweet rice is eaten quickly.
sweet rice is eaten quickly. Dr. Ari, does that make sense?
It does. It does.
What's
I
your
guess.
interpretation of it?
I guess in the African setting, when sweet can be interpreted in different ways. It doesn't necessarily mean sugar sweet. It could be a tasty meal. And certainly when rice is prepared in a tasty way, such as in the West African region, then it there's not normally much left on the plate. That's my interpretation.
I like you, Doctor.
Whoa. Man, she's going to print the whole day.
In fact,
Sour.
these people
What is
have
that thing?
suffered.
That rice called jalopy?
Jollof.
Oh, sorry.
Doctor knows what she's talking about.
Okay.
Jalopy rice.
Sorry.
I know where to find you.
Jollof rice.
Jollof rice.
So it's about something that's good. It'll be consumed or grabbed very fast. Okay. Now, I've given some statistics that I saw somewhere. Please give us those statistics again now from the expert perspective.
Yeah, that's right. So I think the background of this work really came from the devastating impact that unfavorable outcomes of pregnancies are having on families, on women, and on society as a whole. Now, globally, every year, approximately 2.3 million neonates, those are infants who are born in the first 28 days, will die. The majority of those will die in sub-Saharan Africa or Southeast Asia. And the global community has given us targets to meet in order to address this, to bring this down. And according to the Sustainable Development Goals that we are working towards, we need to bring the rates of neonatal deaths down quite drastically. Now, unfortunately, in countries like in many African countries, and Kenya is one of them, we are lagging behind in terms of addressing this. And so, as a global community of experts and researchers, and really led, I guess in this particular one was really led by pediatricians, there's a move really to an understanding that actually if we want to have better outcomes for children, we need to look back a little bit and see how the mother's health is doing, especially during pregnancy and then during childbirth. And so the conceptual framework of really looking at which newborns are at the greatest risk of dying came from that. And so we've been looking conceptually at it as low birth weight infants, so those infants who are born small, weighing less than 2,500 grams. But over time, we realized that this doesn't really cover all the at-risk newborns. And so the new concept that this series is bringing out is that we have a concept called the small, vulnerable newborns. So these are newborns who are born too early or too small. Some of them may be too early and too small. And so therefore, bringing these numbers together, there are 35 million in total.
35 million what?
Newborns who are small and vulnerable, who are born every year. And so bringing these numbers together really helps us galvanize the policymakers, the efforts from policymakers, funders, to really say, look, this is a big problem. And before we used to just look at those who are born alive, but now what our series is showing is that we've also included those who are born stillbirth, as in when they're born they're not alive, but they've still been born small and vulnerable. And so I think really bringing that to the forefront is the purpose of this work that we've done.
What is too soon?
So too soon, as you quite rightly say. So gestation is, the number of weeks that, a child is in the mother's womb from conception right through to birth. And for normal term, we expect an infant and fetus to remain in the womb for 37 weeks. But if they're born before 37 weeks, then we say they're born too soon. And those infants are all at risk of different problems, depending on how early they've been born.
Okay. So, I mean, of course, there's so many questions that come up to this. But one of the things that you said is that, punching below our weight, no pun intended, when it comes to these children. But then we're saying that there's a target that should be hit. That almost says that there's something that can be done about this particular issue. And sometimes you say, well, a woman is pregnant, that there's very little she has control over. But we're saying that there is something that can be done about these children that are born too small or too soon. And is that what we are saying? That there actually are interventions then that can be introduced to stop this from happening?
Correct. And I think that really almost is the first step of this series, really to highlight the fact that when we practice medicine now, we're trying to practice it not based on expert opinion only, but based on the evidence that we get from the research. And so within this series, all the research that has been done around these 8 interventions that are highlighted was reviewed and summarized in the series. And indeed, during pregnancy, so this series highlights the interventions that can be done during pregnancy to prevent these infants from being born small and vulnerable. So there are 8 in total. Now, we know that WHO recommends that women have 8 contact visits with a healthcare provider, 8 contacts with a healthcare provider. In Kenya, I think...
During pregnancy?
During pregnancy, absolutely. In Kenya, I think we at the moment, the recent Kenya Demographic Health Survey shows that, a good proportion, probably about 60% of women will get 4 visits. But obviously, we need to have a few more visits.
There should be 8.
The 8 contacts with a healthcare provider, so they don't necessarily have to be visits.
Okay.
8 contacts. Now, during these visits, obviously, what we are pushing for in our series is that the visits need to have, we need to provide quality care for pregnant women during these visits. And so the interventions that we've highlighted, we know that for majority of women, particularly in Africa, they will not receive those interventions during these contact visits. And so what we are pushing for is for efforts and investments to be put in so that all women have access to these interventions. So one of them is, for example, micronutrient supplementation, which women in high-income countries will receive as, a blanket intervention. In low-income countries, including in Kenya, women who are able to afford it will have access to that. But women who come from impoverished communities will not have access to that. So we have a group of women who will not have access to all these interventions that we've highlighted that are evidence-based that could prevent.
I think even sounds
infants.
complicated already. Micronutrient supplementation.
Yes.
What's that?
So micronutrients are vitamins and minerals that enhance both the way the body works and the way babies grow. So, for example, the common ones that we know are iron, zinc, folate. Yeah, those are the common ones. But you have when you have a package of micronutrient supplements, you have about 15 of them combined together. And a lot of research has shown that these are, certainly from our series as well, that if women are given appropriate amounts of micronutrient supplements, in addition to all the other interventions that we've stated in the series, that there is potential for us to actually reduce the number of newborns who are born small and vulnerable.
Supplements. What do you mean, supplements?
So supplements are, we would like women to have a healthy diet during pregnancy. Often, there will be things lacking, but pregnancy is a unique part. I'm a pediatrician, so I'm not going to claim to be an expert in talking about pregnancy. But certainly from my point of view as a pediatrician, we know that as the fetus is growing, there are extra requirements on the woman. And so these micronutrient supplements just help to enhance that process of the growth of the fetus, but also keep the woman healthy.
And are these micronutrients available in the foods people eat? Or are we saying that in case the diet that the pregnant woman is on doesn't have them, then you need to give them a boost?
Yeah, so I think pregnancy is a unique time. And as I say, I'm not an expert in pregnancy because I'm a pediatrician. But we know that because of, as I've said before, even if you're having a generally healthy diet that you'd expect to have all the general nutrients, you need a boost during pregnancy. And just because, as I say, you have that growing fetus in you. And I think, certainly from the research that we highlighted in this series, that all pregnant women require this micronutrient supplementation in addition to, obviously, the diet that they're having in order to prevent the small and vulnerable newborn. Now, in communities where women are not really able to access a healthy diet, the series also shows that those women need to have supplementation, so additional protein and energy supplements in combination with the micronutrient supplements in order to avoid having a small and vulnerable newborn.
I want to take you back to something you said. This relates to children who are born small. Okay? That presupposes that there is a size that is considered normal, isn't it? Okay? Now, does this then contribute to the size that someone can grow to in later years? And if you're born small, what is it? I mean, is it genetic that perhaps your parents were not huge in body, and so genetically you start off small? Or is it, again, this same issue of what it is that your mother ate or what is your mother eats? What is it?
I think it's a combination. It's quite a complex mix of all these factors that you've quite clearly mentioned. What our series focuses in on is that when you say small, it means when babies are born, they have a weight that's lower than other babies with that gestation. So we say 10% below the 10th percentile. Now, if you're born small, we know that this is very much from research that in the long term, catching up may not be so easy. Some will, especially if you're in an environment where a child is able to thrive. But if you're not, then in terms of the long-term outcomes, you're more likely to get, for example, heart disease, diabetes, and things like that. But in addition to that, when you look at it at a child level, there are issues around this, the neurodevelopment and how a child develops intellectually. If you're born small, you're likely to have, kind of like your ability to learn will be a bit slower. And that means in the long term, your ability to earn and an income for your family becomes lower. So I think what we are, in this series, what we are looking at the small and vulnerable newborn topic as a life course. We're looking at it as a life course approach, starting in pregnancy through to birth, through to the newborn, but also really looking at what the long-term outcomes will be if we do not address this issue urgently.
So are we seeing a direct correlation? And when we say born small, essentially, this is in the same line as being born prematurely. So there's premature in terms of time.
Too early.
And then there's premature in terms of size, right?
So
that's 1A. So 1B would be, do we see a direct correlation between this prematurity at birth and these things that you've talked about? Can we actually see numbers and say, if 100 children were born and 50 of them were born prematurely, the majority of that 50 will present with some of these issues that you've talked about?
Yeah, I think in an ideal world, we'd be able to tease that out. And just to clarify that, when you're born small, you may not be... when you're born small, you may not necessarily be premature.
Right.
So that's the complexity in terms of how we've tried to bring out the new conceptual framework. So you can be premature but not small for your age.
Yeah, I think the tallest man in the world is 7 feet, and he was born at something like 30 weeks.
That's right. Yeah. That's right. Our challenge in our context is that, and that's what the series also kind of like tries to highlight, is that our measurements are not accurate enough for us to make those predictions right now, because for majority of women pregnant women will not have an ultrasound scan, and we know the ultrasound scan will give us the most accurate assessment of gestation. So they will not have that. In addition to that, when babies are born in a lot of our hospitals, they will not have an accurate measurement of their birth weight. So often that data is not there for us to predict. So with the current estimates that we have, often from data that is not as good as we'd like it to be, we know that we have data, majority of these small preterm, small and babies who are born small and early, we've classified them as low birth weight babies just because we are missing all those specifics in the accuracy. A large proportion of them, some studies have shown that up to 66% of those will have some form of neurodevelopmental impairment by the age of 2 years. But that's really from data that, as we are saying, is not adequate in terms of enabling us to really make those accurate estimates. So what we are calling for is more accurate estimates, more accurate measures, so that we can make better predictions in terms of their long-term outcomes, and then put more interventions in place for these babies when they're born.
I guess measurement is another intervention then.
Correct. It is another intervention, and actually...
Of the 8.
Yes, absolutely. And actually, yes, what a recent study that's been published from Kemri in Kisumu have shown that actually just by measuring, that makes a big difference. And we are definitely underestimating the numbers
But then,
at the moment.
This measurement, from what point are we starting to measure? You've mentioned things like ultrasound during pregnancy, so that you know the gestation and how it's going. You've talked about at birth and weighing the child, knowing their weight, knowing all those things. So at what point are we starting to measure, and what are you advocating?
Okay, so as I say again, I'm not an obstetrician to measure it, but certainly I think as early as possible, especially for women, once women, feel that they're pregnant, then they really need to attend healthcare facilities to identify. We would like to measure in the first trimester, so almost that first 3 months. It would be great to be able to start measurements then. But certainly my obstetric colleagues will be able to give you a more refined answer to that question. For the newborn, it's immediately they're born. We would like them. So not immediately, because obviously there are other things that need to take place when a newborn is born. It's skin to skin with the mother, the breastfeeding needs to start. But when all that is done, within the first 24 hours, we need to have a weight, an accurate weight for that baby that's recorded appropriately so that we can then track the progress of that infant.
It sounds like a myth to a lot of women, because now we are talking about the actual experience. I mean, there's the science of it, but a woman who pregnant at some point or another will change in her desires for food. And we've also seen that bears weight on her nutrition. Now, there's also the thought in the minds, you'd be surprised, a lot of women who feel, look, the system has already been created. It is there. The child is going to get the nutrients that they need, whether I eat or not, whether I snack on cookies because that's what I'm craving, or whether I eat green vegetables or chalk, whatever. The thought in the mind is that, look, the child will get what it needs. The umbilical cord connects us both and we are fine. Are we now saying that from what we've been able to see, that is just not true?
That's right. I think in terms of certainly the way we're going in terms of practicing medicine, we're trying to have a more integrated approach. So you don't, when you come, for example, when pregnant women come for clinics, it's not just seeing obviously the medical teams who sort out the ultrasound scan and all the other things, but actually seeing people who are experts in nutrition to actually assess what the quantities are. Are these adequate, and what else do you need? But certainly, as I've said, the multiple micronutrient supplementation, that is required in pregnancy, just as all women now receive iron and folate. So what our series is showing, that this is superior to the iron and folate. So it would replace the iron and folate supplementation. I think just to answer your question in summary, I think when women feel they're having, they feel they're having enough, they probably are not, and actually really need to seek medical help and attention to get that advice that they need for a healthy baby. So we want a healthy mother in pregnancy to get a healthy baby.
Right. And for that healthy baby then to also become unhealthy adults.
Correct.
Okay. So the journey of you and where you are right now basically was impacted a lot by the journey of your mother during pregnancy. That's what we're saying.
Correct.
And it's important then that for all of us to think about that journey of a mother, a pregnant woman, and what she's going through as she is nurturing the baby in her womb.
Yeah.
That's a conversation we're having this morning with Dr. Hellen Nabwera, who is an associate professor, physician scientist at the Aga Khan University. She's part of a global team of experts who've been working on some new research that they've recently published, right?
Yes.
And it's looking at that journey and what happens to children, babies, as they're developing in their mother's womb.
Correct.
And at birth. You're calling that concept small what?
And vulnerable newborns.
Small and vulnerable newborns.
Yes.
All right, let's continue this conversation shortly. What do you need to know? We'll be talking about it.
This is the Situation Room, the only way to start your day.
And Dr. Hellen Nabwera continues. We're talking about small and vulnerable newborns, and their journey to birth begins with their journey from conception and how they are developing in their mother's womb. And you're saying very many things. One, many of the people that you studied and you've seen in Kenya, statistics are showing that many women will have contact with a healthcare provider at least 4 times during pregnancy. And this is just in Kenya. Similar numbers in sub-Saharan Africa?
Yeah, I think it's difficult. Sub-Saharan Africa is quite complex because, especially because of the humanitarian crises in various countries. And our series also brought that out, that actually special measures and investments need to be put in those settings because actually their outcomes will be a lot worse than what we see. So we suspect that the contact visits in some of those countries, especially in having a humanitarian crisis, will be even lower. Some countries will be doing, better. Certainly, possibly countries such as, Botswana, where the healthcare system is quite strong, will be doing better. Yeah.
Apart from nutrition, what are these other risk factors that would lead to small vulnerable newborns?
Yeah. So one of the others that we highlighted in this was infections during pregnancy. And for a number of these, one of the infections is a bacterial infection in the urine that the women may not even know they have. And so that requires an assessment by a medical expert, really. So hence the need for them to attend for these pregnancies, attend clinics to have their pregnancies assessed properly. The other infection that, obviously will be quite common in Kenya is malaria. And what the series highlights is that we need to, number one, treat any of these infections promptly, but also prevent them. So, for example, malaria, we know that insecticide-treated bed nets will be quite effective in preventing pregnant women from getting malaria. So those are the kind of like the key highlights, in addition to the nutrition component.
How do these contribute to then that low birth? What's the connection? So these infections, yes, why would then the baby be born too early? Or why would the baby be born too soon?
Yeah, so the series has a paper that really just focuses in on the mechanisms. A lot of them we are still doing research on to fully understand. But what we know is that when a woman has an infection, there's something called inflammation. So her hormones that, her body system will be fighting that infection. And when the body system is fighting infection, what is compromised are the hormones that then promote growth.
Okay.
So we think that while there's all this fighting, there's stress.
There's a war on one side.
There's a war. So the hormones that are raised to fight the war against the infection, if they overwhelm the other hormones that are, promoting growth, then you have a baby who's not growing well.
It's like a diversion of resources.
Correct.
Resources are being taken by the body
Correct.
to Ukraine.
Yes.
And so
Yes.
Africa gets affected.
Yes.
Okay. Hypertension. And we hear about this preeclampsia and all. Is it a factor as well here?
Yeah, so preeclampsia is an important one. So I'm going to divert you there because I'm not an expert in preeclampsia because I'm a pediatrician. But it is in terms of when you look at especially preterm birth, certainly as pediatricians, when we're looking back into the history of why this baby has been born preterm, preeclampsia is an important one. The series does highlight that somewhat, but in terms of intervention specifically for preeclampsia, the evidence is there. But as I said, yes, a very important topic to discuss, but I'm not the expert to discuss preeclampsia.
But go ahead and do.
What happens when an intervention has to take place for a child to be born early? And it could be complications with that, where an obstetrician will have to go in and remove baby to save both lives.
Yeah.
And obviously that will have an effect on the nutritional development of this baby, which is now some of the things we're trying to avoid by having an early baby, right? So what happens then to then be able to make sure that this child still gets to that percentile?
Yeah. So there are two aspects. You've highlighted obviously nutrition, which is really key for these babies when they're born early. The other aspect is other complications, particularly breathing difficulties. And what this series highlights is that actually at that point where you cannot avoid that baby coming, you can provide things called steroids to that pregnant woman to help mature the baby's lungs so that when they are born, their breathing is not so labored. Yeah, so that's one. And then the other one is to slightly delay what they call delayed cord clamping. So just delay cutting that, clamping that cord before releasing that baby from the mother. That again has been shown to, to be quite effective, reducing, for example, incidence of anemia.
What's delay? How long?
So 3 minutes. Is delay. Good question.
Wow. I was going to say
3 minutes.
Day.
3 minutes. So instead of rushing and saying, oops,
I was thinking a month.
So delay, yeah. So that's a good question. So I think those are the things that, at birth, the obstetrician can actually do to support us in terms of when the baby is born, what we need to do. Neonatal nutrition for these small and vulnerable newborns when they're born is really critical. Breast milk is best in this case as well, but obviously there needs to be support in providing that breast milk. And certainly in our setting, there's still, we still have a bit of a long way to go to really, optimize that aspect of supporting women in those first few hours to ensure that that baby gets the nutrition that they really need, even though, especially because they've been born small and vulnerable.
At what age does a child stop going to a pediatrician?
Yeah, it's a good question. It depends. We say 18. Pediatricians really struggle letting go of children who they're looking after. We really struggle with that. Normally, it's 18. Sometimes we go
18
beyond 18 years of age. Sometimes Sometimes it's earlier. It depends on how mature that child is. Sometimes it's late, especially if they've got an ongoing problem that you've been managing for a long time, and the family really, trust you. Then sometimes that's prolonged.
You have.
It's a good question.
You have neonatal experts, huh? Then you have pediatricians. Do you have adolescent practitioners?
Yeah. So adolescent health is a growing specialty. I think there's a realization that adolescents have their unique challenges, so we cannot treat them like children anymore, and we cannot treat them as full adults. And so I think there's a growing group of experts who just focus in on adolescent health, which is quite complex in itself.
So when they determine the age at which pediatricians, now generally speaking, manage the lives of children, what are they looking at? The developmental process of their brains and their capacity, or the chronological process that they've gone through? What are you mixing? But what are you looking at?
It depends. So for the small, if you go to the small and vulnerable newborns, what you want to see as you're following them up over time, especially in those first 24 months, but also normally the first 5 years, you want to make sure that they're growing appropriately, that they're getting adequate nutrition to grow both in height but also in terms of weight, and that they're proportionate, because you don't want them to become obese, because then that again increases their risk of cardiovascular, of heart problems and things later on. We also want to make sure that in terms of their development, so not just intelligence, their ability to move, their ability to do just function in life as normal as you would. So we are preparing them for school. So we want to ensure that they're prepared for school. And if they've got problems, for example, with vision, seeing, which quite a number of preterm infants may have, or a problem with hearing, we detect that early, and we put measures in place to ensure that these children are ready for school.
When you talk about everything we're talking about,
yeah,
there's the period of time when the child is within the mother, okay? Now, everything we're saying seems to focus on nutrition and health. Now, what is it that interferes with the health directly? Probably diseases. So within that ecosystem, if a mother is predisposed towards some diseases, I suspect the child will also be affected in one way or the other. But there's something else, because we're talking about stunted growths. There's what you call a social stimulation, the environment. Now, when one grows up, when one has started growing, where they live specifically, that stimulation within that,
absolutely,
that also influences them enormously, does it not?
Absolutely. And that's really a really critical point that you raise. Yes. And we see that difference even, within, when we do research within sub-Saharan Africa, that you find children who are, grow up in a less adverse environment, even if they are born small and vulnerable, have better outcomes than those who grow up in impoverishment. And so, some part of what we are calling for in this series, but also in our ongoing research, is that we're able to make, to support families whose children are growing up in these communities to have, again, more stimulation, added resources to ensure that, we give them the best chance at being, growing and attaining their full developmental potential, but also growth potential, but also ongoing health outcomes as well. That's a really good point. I think the issue of social inequities is really critical in this whole process. Yeah.
I'm thinking about what you talked about earlier, and I think because there could be a pain point where we're saying that a child born early and born small then faces the risk of certain complications later on in life, and this is based on nutrition, right? Kind of like when you say somebody is deprived of oxygen for a period of time, it causes untold damage. Yeah. Now, if this damage comes as a result of nutrition, what's to stop reversing the problem by giving the right nutrition after this child has been born? Yeah. Can you reverse this?
Yeah, I think that's what we attempt to do as pediatricians, that we really try and optimize their nutrition once they're born. We may not fully reverse what's happened. We not fully reverse the adverse outcomes, but certainly we can mitigate and make them, kind of like alter their path going forward. But I think really the emphasis for this series is just that if we can prevent, then by the time they're born, we can continue optimizing and really optimizing their outcomes. But yeah, I think it's a good point. We can't fully reverse. We can absolutely try and optimize that nutrition to enhance their growth and development.
An area of concern is also where the majority of these mothers are domiciled, in terms of their access to healthcare and this information, in terms of their access also to proper nutrition. We can't run away from that fact.
Correct.
That there are already predisposing factors that make this whole problem even worse.
Correct.
We're dealing with so many things at the same time.
Yes.
And even as the finger is being pointed at us to say, look, let's get these numbers up. Or in this case, get these numbers down. That nutrition is going to be an issue because of poverty. Nutrition is going to be an issue because of knowledge and information. And also when we look at something like universal health coverage, which is being discussed today, that they are predisposed to this and almost that there's nothing we can do. So how is this being looked at vis-a-vis the reality on the ground in terms of access?
Yeah, absolutely. I think in this series, obviously, we've highlighted the 8 evidence-based interventions that can work. But in work that's been done before, the Every Newborn Action Plan and things, I think there's really that realization that unless we address the social determinants of health, we are unlikely to, get the gains that we are hoping for. And so what our series really highlights is that, yes, indeed, we need to invest in these interventions, but we also need to address the issues around social inequity and the social determinants of health, and to ensure that there's equity in access to healthcare for all women, not just women who can afford to pay for it, but for all women. And I think, for many African countries, and I would say Kenya included, we still have some way to go in terms of making that possible for all women.
Do these supplements need to come packaged? Or is there something that women can be advised in various communities? Make sure that when a woman is pregnant, they're having this kind of diet, and then they eat a lot more of, plus those rocks, plus...
Yeah, so I think,
so
rocks used to be... I think in this era of of evidence and things, we can only recommend what we've been able to measure and study and have confidence in. So the multiple micronutrient supplements have to be produced through the pharmaceutical industry. And I think, global partners often, provide that support. But there's a push towards seeing whether actually, countries can produce some of these locally so that they make them more affordable for all women within, for example, our African context. So absolutely, that's been thought. So I can, unfortunately, yes, there's that advice that you can give in terms of nutrition and what to eat, but even with that, you still need evidence more. Still shows that we still need to give them the micronutrient supplements. So, for example, one of the micronutrients we're talking about is folate, and folate, our diet doesn't, especially in some African communities, doesn't have anywhere near enough folate. And folate is really critical in the way the spine develops in infants. And so you'll find in communities where there's very little folate, there's an increased risk of having babies born with defects on the spine. And so, as I said before, because of that additional requirement for the growth of these infants, we need to add, provide them as additional micronutrient supplements.
The other thing I find interesting is, if I were to take what you just said to its logical conclusion, then I'd be concluding that people who do not have access to some pharmaceutical solution are done for, because you are doomed. There are certain negative outcomes that must visit you. Let me just ask, in all honesty, are we saying that the foods that are available to us on this planet cannot actually provide what the pharmaceutical solutions provide?
I think there's always ongoing research in terms of seeing, okay, what is best and what can we do better. So as where we are now, we know that yes, a woman would advise her to get an adequate diet, but they still need these they still need these additional micronutrient supplements in order, particularly from this series, to avoid having a small and vulnerable newborn. But I also have talked about the other complications that potentially could happen. I know that dependency, I guess, on the pharmaceutical industry, you could, that's a discussion for another time. It is a topic on its own, but it's like I would look at micronutrient supplements as almost like a medicine that woman needs to have for a safe pregnancy.
You know where I'm going at this? I'm looking at very many pharmaceutical products. Many of them are derived from plant extracts, or they are derived from living creatures, living things. Now, there are some which are perhaps just laboratory enhanced and made. I understand all that. But the idea that, I'm not saying that it is not true, it's the idea that in the absence of the pharmaceutical intervention, one is doomed. I'm using a strong term because I want to amplify this. That is a rather serious doomsday scenario as far as I'm concerned. Yes, because I'm looking at people who live in resource-starved places, whether they're in the urban areas or in the rural areas, where access to a healthcare facility, I think you know where I'm going with this. And I'm thinking, so what happened to these people?
Yeah, and I think that's what the series is all about. And I think that's it. There shouldn't be a woman who cannot access a healthcare facility. That shouldn't be happening. And we know that if that happens, if a woman is not able to access the healthcare that she needs during her pregnancy, then she's likely to have an adverse outcome. Yes, both for her own health, but also for the health of her newborn. And that is it. When we've in one of the papers, it's a call to action. It's a call to action in terms of, yes, changing policies to incorporate these key interventions that we've mentioned, but it's also a call to action to improve the quality of care and make healthcare accessible to all women, irrespective of where they are.
This accessibility to healthcare is being touted quite a lot, and my hope is that it actually becomes a reality when we look at UHC. So the practice before has been to implement the operation of CHVs, or CHPs as they're called, community health volunteers, community health practitioners, within the country, who will then be on a stipend. Would you see this as an intervention whereby because you talk about the 8 contacts that should be had in pregnancy for a woman, wouldn't this be a place where this information could actually be shared? Because I could be wrong, but I feel that a lot of this is because of lack of information.
Yeah, absolutely.
Is that where that could come in?
No, absolutely. And I think when WHO set out to do this, there's a move towards not just providing healthcare in healthcare facilities. To improve access, we've got to strengthen what's happening at the community level. And yes, indeed, those contact visits, some of them can happen at home, but you need to have an informed healthcare provider to provide that quality. So we want good quality care at the health facility, but also at the community level. So it's ensuring that we are equipping them enough with the knowledge to actually provide the care, the optimal care that these women need during pregnancy.
But the data that you started with was 1 in 4 births across the globe.
Yes.
You said it's amplified more in sub-Saharan Africa, in Africa and in Asia.
Yes,
but it's across the globe.
Yes.
Even in those societies where they have access to healthcare, they have access to diet, they have access to all these things. So what is it that causes the SVNs in those other economies?
Yeah. So again, I'm not going to veer too much from my area of expertise, but certainly conditions, complications in pregnancy such as preeclampsia that you'd mentioned before will contribute towards that. I think the global pattern in terms of what the risks are, we've talked about the relevant ones, but the numbers, if you look at the actual numbers, the majority will be happening here. So certainly in high-income countries, complications such as preeclampsia, but women with more complicated problems are being supported to go into pregnancy as well. So that could contribute. But as I say, that's not my area of expertise. But the focus really for this series was, yes, it was global, but it was really highlighting where we need to put the investments to address this problem. And that's in Sub-Saharan Africa and South Asia.
Can I ask a simple question?
Yeah.
This study that you conducted,
Yeah.
okay, methodology.
Yeah, so it's interesting. It wasn't one particular study, so it was basically pooling together. So it's something called, we pull together research studies that have already been done, synthesize them, bring them together, and then come up with a summary endpoints in order to influence policy. Yes, so it was that kind of, I would say, desk-based. So you're using what's already out there, the data that's already been collected and published, and you're using it then, pulling it together, using it then to inform policy. And it's very powerful when you have the large numbers, especially when you're pulling data from different settings, to bring that together to then help inform
So what
policy.
do you call this consortium that you've just referred to?
So it's a small and vulnerable newborn consortium.
So essentially what you're saying is it's comparing, contrasting outcomes that have already been proved in other studies and looking at the directions in which they purpose to go and the outcomes, and then looking at how this relates to
Yeah.
this very specific area that you're talking about.
Correct, because when you do research, depending on the context you're doing it in and when you do it and how you're doing it, sometimes the findings you can get different findings and then you get quite confused. So this method that we've used is really pulling together all these sometimes contrasting findings, pulling them
from
together.
different parts of the world.
Yes, pulling them together to then get a definitive answer to the questions that we raised.
The thing about research tends to be specific.
Yes.
Yeah. Yeah.
So you're looking at something specific. Now, what didn't they cover?
No more questions, City.
All right, sorry.
Time is over.
Next time, when you come back, we'll start with that question.
We can focus on research.
We'll focus on the research.
Child health research.
Dr. Ari, thank you very much for joining us today.
Thank you very much.
Dr. Hellen Nabwera is an associate professor, physician scientist at the Aga Khan University. We've been talking about this research that's been conducted by various experts across the globe, something that they're calling small and vulnerable newborns, and what can be done to address that. Thank you very much for tuning in to Kenya's biggest conversation, The Situation Room. Have a lovely weekend. I'll not be in from Monday, but Ndu and City will be here, certainly. Enjoy.
This is The Situation Room, the only way to start your day.